Okay, it's striated. Anything else? Some specific unique properties that you remember about? Involuntary is there. Anything else that you can think of? Very good. Intercalated, isn't it? What do you mean by intercalation or intercalated discs? Anyone has any idea what it means? Anyone? Samrat Paulel? Nobody. None of you remember.
Yes,
what do you mean by intercalated disc? What is the significance of this intercalated disc? Do you remember? All right. Okay, so the significance of the intercalated disc is that nobody can tell. Pratisma?
Ma'am, it kind of provides union or fusion between the muscle fibers.
That is very good. It is the site of union between the cell membrane, or it represents the union or meeting point of the cell membrane. So what exactly is its significance is my question. Why is intercalated disc such an important feature of cardiac muscle? All right, Rajiv, I will not ask you anymore.
Work as a single unit.
Very good. It functions to provide the heart the ability to work as a single unit. What is that single unit? There is a specific term for it. Does anybody remember? Have you been told about Somebody said something. Speak up, guys. I'm not even able to see you. What is your fear? Don't fear anything. I mean,
syncytium.
Anybody has very good syncytium, Ujjwal. Good. It is called as the syncytium because of the anatomical characteristic of the cardiac muscle, specifically the intercalated disc, which represents the site of union between the cell membrane of the multiple cardiac cells. This allows the cardiac cells to function as a syncytium. So when we say it allows the cardiac muscles to function as a syncytium, it means that because of the presence of this intercalated disc, which is a site for the union of the cell membrane of the cardiac cells, there are various gap junctions. And we know, and we've studied about gap junctions in the previous semester, if you remember or if you recall. So these gap junctions are actually they are the method of communication between the cells, which allows very, very easy passage of ions and very easy passage of the cardiac impulses. So if one cell is depolarized, or if one cell is stimulated, the depolarization spreads so fast that the entire unit, the entire muscle mass will contract as a single unit. So this allows for the heart to contract, but then there is a specific syncytium. There is also the atrial muscle mass is called as the atrial syncytium, and then there are ventricles which form the ventricular syncytium. So it allows the atrium to contract as a whole unit, as a single unit, sorry, like at the same time. And it is arranged such that the atrium contracts ahead of the ventricles, and that allows for the proper feeling of the ventricles. So whenever the atria contracts, the blood that is present within the atrial chambers will flow to the ventricles, and only after that does the ventricles contract. So this presence of the intercalated disc will allow the cardiac muscles to act as a single unit, thereby functioning to allow the cardiac muscles to contract simultaneously. Okay, so I'd like to say there are also other characteristics like how the cardiac muscles have a specific lattice work like network, which means that the cardiac muscle fibers are dividing and then they are combining and they are again spreading. So this kind of spread or this kind of distribution is also seen. Like the skeletal muscle, these fibers are also striated, and if you compare it with the skeletal muscle, it is also composed of the contracting filaments like the actin as well as the myosin. But the difference is the presence of the intercalated disc in case of the cardiac muscles. And this presence of the intercalated disc allows the rapid diffusion of the ions, rapid diffusion of the rapid conduction of the impulses, which allows the heart to function as a syncytium, so that whenever one cell becomes excited, the action potential will spread rapidly to all the cells of the heart. All right, so this is just a general introduction about the anatomical characteristic of the cardiac muscles. So I'd like to share my slide so that you can have a look and you can follow what I'm trying to say. Okay, so give me a second. Okay, can you see the slide? Students, can you see the slide or not?
Yes, ma'am.
Yes, ma'am.
All right. How do you do this? This is more easy. All right, so if you take a look, this second slide demonstrates the anatomical properties or the anatomical characteristic of the cardiac muscle. So you can see here that is my voice visible? Can you see, can you hear my voice or not? Is it clear?
Yes, ma'am. Yes, ma'am.
All right. All right, so so you can see here in this diagram that the anatomical properties of the cardiac muscles has been depicted. So it is arranged in lattice work, meaning that there are the fibers that are dividing, that are redividing, and then that are spreading again. It is striated, the presence of these dark areas, which are called as the intercalated disc. This represents the site of the fusion of the cell membrane of the cardiac cells. Similarly, there is also a presence of the, so this also represents the gap junctions, which allows for the transfer of the ions as well as the rapid conduction of the impulses from one cell to the other cell. So having said this, let us go to the third slide. So can you see it? So it is just what I have explained in the previous slide. So we can just go through the text that has been written on the slide. So the cardiac muscle fibers, they are arranged in lattice work with the fibers dividing, they are recombining and then spreading again. They are striated, the same as that of the skeletal muscle. Similarly, it also consists of the contractile elements, which are the actin and the myosin, and they lie side by side. Okay, so during the process of the contraction, which is also similar to that of the skeletal muscle. But then the factor or that the fact that separates the cardiac muscle from the skeletal muscle is the presence of the intercalated discs. So this intercalated disc actually they represent the site where the cell membranes are fusing with one another, or these are the cell membranes that separate individual cardiac muscle cells from one another. So this intercalated disc, the presence of these intercalated discs throughout the cardiac muscle allows the cardiac muscle to act as a syncytium. So when we say syncytium, it means that it allows the cardiac cell to function or to function as a single unit. But then if we take a look at the cardiac cells, which consists of gap junctions within the intercalated disc, it allows for the easy passage of the ions, easy conduction of the impulses, that is the action potential from one cell to the other cell. But like I've told you, the atrial muscle mass forms a separate syncytium, which is called as the atrial syncytium, and then the ventricular muscle mass forms the another separate syncytium, which is called as the ventricular syncytium. And the function of this syncytium, the significance of having these two different groups of syncytium, that is the atrial syncytium and the ventricular syncytium, is that the atrial will contract a slight period, it will ahead of the ventricular contraction, meaning that whenever the impulse is generated in the SA node, this impulses will cause the contraction of the atria a slight moment ahead of the ventricular contraction. And the significance of it is that the atria, while it contracts, it will allow the sufficient time for the blood to be filled within the ventricles. So when impulses are transferred, the atrial muscles contracts first. So this contraction of the atrium will cause the blood to be squeezed out of the atrial chamber into the ventricles. And then only after that does the ventricle contracts. And then once the ventricle contracts, that is essential for transfusing or transporting to blood to other parts of the body. So basically it is affecting the effectiveness of the pumping of the heart. Understood? So this is about the anatomical characteristic of the cardiac muscle. So after having been acquainted or after having knowledge of this general outline or this general knowledge of the cardiac muscle anatomy, we can now proceed with the physiology of the cardiac muscle cells. So there are four basic properties, physiological properties of the cardiac muscle cell. That is, number one is excitability. So you know what excitability is. You've already studied about the excitability of the nerve, excitability of the muscle when you were in first semester during your basic courses. So when we say excitability in physiology, it means that the cell is capable of responding to a stimulus. So whenever a sufficient stimulus is applied, it will generate, or it will be followed by the generation of an action potential. And this action potential will finally result in the response, which is usually, in case of the muscle, it is the contraction of the muscle. So this ability of the cell to respond to a stimulus and in response in turn produce a response, which is usually a muscle contraction, that is called as the excitability of the cardiac muscles. So this is one of the very important properties of the cardiac muscle. The second important property of the cardiac muscle is the ability of the heart to conduct the impulses. So the impulses that are generated within the heart has to be transported or should be transmitted through the entire heart for the efficient functioning of the heart. And that capability of the heart to conduct the impulses, it is called as the conductivity, or the characteristic or the property of conductivity. And I've told you that the conductivity is also facilitated, this quick conductivity is facilitated by the presence of these gap junctions throughout the heart or the cardiac muscles. So the third important property of the cardiac muscle is the ability to contract. That is, the muscle has to contract. In order for the heart to pump out its blood, the atria has to contract to pour the blood from its atrium to the ventricular chambers. The ventricles has to contract in order to pump the blood out from the heart throughout the parts of the body. So this property of the heart to contract its muscles, the cardiac muscles, that is called as the contractility of the cardiac muscle. Similarly, we also know that the heart has or heart beats in a very rhythmic pattern, and that capability of the cardiac muscle to beat in that rhythmical manner, that is called as the autorhythmicity. So these are the four basic properties of the heart, and with the proper only if all these properties are appropriately maintained, and if all these properties are intact within the cardiac muscle, can a heart function properly and in a good manner. Any kind of abnormality, say with the excitability, any kind of abnormality with conduction, any kind of contractility, abnormality, or any kind of abnormality in the generation of the rhythmical beat can result in the, or it denotes the pathological condition of the heart. Understood, everybody? Yes? Am I audible?
Yes, ma'am.
Yes? All right. So I'll proceed with today. We will study a little detail about the excitability, and if we have time, then we will start with the, carry on with the conduction also. So the first thing first, let's start with excitability. So I've told you the excitability, you know what excitability is. Once again, to remind you of what you have studied, it is the ability of the any kind of excitable tissues like this, the cardiac muscle here, in the capability of that muscle to respond to the adequate stimulus. And how it does that is followed by the generation of an action potential. And following the generation of an action potential, there will be the response that is achieved is the contraction of the cardiac muscles. So there are various factors that increases the excitability of the heart. There are various factors that reduce the excitability of the heart. So the factors which increases the excitability of the heart, they are called as the positively bathmotropic factors. Similarly, there are certain factors which reduces the excitability of the heart, certain conditions, certain diseases, certain drugs. So any factors that are responsible for decreasing the conductivity of the decreasing the excitability of the cardiac muscles, they are called as the negatively bathmotropic factors. So you have to remember the term bathmotropic. It refers to the factors that affect the excitability of the heart. All right. Clear, students, till now? Just started, I guess. Okay. Now, if we're looking at the cardiac action potentials, so you know about action potentials, you've studied about the action potentials, you know what are the general phases of the action potentials, especially in the skeletal muscle fiber or in the nerve. So you've seen that it usually consists of, there is a resting membrane potential, and then once a threshold stimulus has been applied, the potential raises, and that is called as the depolarization. And then following depolarization, there is repolarization, and then hyperpolarization. So these are the phases that you know. In general, you have concept about the ionic basis of these phases of the action potential, but it is slightly different in case of the heart muscles. So we will take how it is different in the cardiac muscles regarding the excitability of the cardiac muscles. So if we take a look, then we know, and you must have come across that cardiac, the heart itself, it is composed of the very quickly conducting cells. There are very rapidly conducting cells, and there is a group of cells which conduct the impulses rather slowly. So there are, depending upon their capability to conduct the impulses, they are called as the slow potential and the fast action potentials. Okay, so if we take a look at the slow potentials, these slow potentials are usually seen in the pacemaker areas. So you know that the pacemaker areas, or rather the conductive unit of the heart, which are responsible for conducting the impulses. There is a whole conductive system within our heart, which comprises of the SA node, the AV node, AV bundle, and then there is Purkinje fibers. So this ultimately make up the conducting system of the heart, and basically in those areas the potentials that are generated are slow potentials. But then there are other parts of the heart, especially the atrium and the ventricle. These are very contractile. This atrium and the ventricle are composed of very contractile as well as the conducting cells. So in this cells, or in these areas, they are characterized by the very rapid depolarization. Okay, but then if we take a look at slow potentials, the slow potentials are usually due to the opening of the calcium channels or influx of the calcium channels. But if we take a look at fast action potentials, it is often seen that the ion that is responsible for that fast ionic potentials are the sodium channels. And if you recall what you have studied in your previous class, in your previous semester, where you have studied about the skeletal muscle, isn't it? So in skeletal muscle, what was the channel that was opening for the, like after the threshold stimulus has been reached, which channel opens that causes
Sodium.
depolarization? Yes, it was fast sodium channel. So it is the same in case of the muscles of the ventricles and the atrium. Understood till now? Yes? Yes or no?
Yes, ma'am. Yes, ma'am.
So now we will study in a little detail about the fast action potential. So the fast action potential, like I've told you, is usually seen in the atrium and in the ventricle, but many of the studies have been done in the ventricular muscle fiber. So whenever a fast action potential within the cardiac muscle has to be explained, we generally take in consideration the cardiac muscle in the ventricle, that is called as the ventricular muscle. So if we take a look at the ventricular muscle fiber and its excitability, it is often seen that the normal
resting membrane potential of a ventricular muscle fiber is between -85 to -95 millivolt, and on standard it is about -90 millivolt. So you can see here this diagram that I've placed here. You can see how it is different, looks a little different, isn't it, than the action potential that you are usually used to seeing in case of the skeletal muscle. Because in case of the skeletal muscle, there is a resting membrane potential, phase of resting membrane potential, and then there is a phase of depolarization, and immediately there is a phase of repolarization, and maybe there might be hyperpolarization, and then it comes back to the resting membrane potential again. But you can see here for yourself in this graph that it is quite different than that of the skeletal muscle fiber, isn't it? The action potential that is seen in case of the skeletal muscle fiber. So you can see here that there is similar to the skeletal muscle fiber, there is a phase of the action potential, and then you can see a slight phase of repolarization, but then there is this stable phase here, which is unique and is seen especially only in the cardiac muscle fiber. And then after staying in this stable period for quite a time, then only there is the phase of repolarization that you can see here in this diagram. So the uniqueness of this uniqueness of the ventricular muscle fiber is that there is another ion that is responsible for this phase, this stable phase, which is called as the plateau phase. You know what you mean by plateau? It is a flat surface or flat area, isn't it? In general terms, plateau usually means an elevated area with a flat surface. So here also you can see a somewhat flat surface here, or flat region here, or flat curve here, and that flattened curve is called as the plateau phase. And this is how it is different from the skeletal muscle fiber. And the ion that is responsible for generation of this plateau phase is also quite unique. So what are the ions that are responsible? Let's take a look here. So before I proceed, it is important that you at least keep in your mind how it is different from the skeletal muscle. Number one, in case of the skeletal muscle, the involvement of the ions was sodium and potassium only. In this case, there is an additional ion that is involved in generation of action potential, especially the plateau phase of it, which is the calcium channel. Similarly, there is no plateau phase in case of the skeletal muscle fiber. But in case of the cardiac muscle fiber, this plateau phase is a unique distinguishing feature of the muscle fiber itself. So let us take a look at the various phases. Whenever you're asked to write about the various phases of the action potential in case of the cardiac muscle, so there are various phases. As you can see here, it is clearly very nicely mentioned in this graph that you can see here. Even the ionic basis has been explained within the graph. So you can see here that the resting membrane potential, as is seen here, is the resting membrane potential is -90 millivolt. Okay, so after this 90 millivolt, then whenever the threshold stimulus is applied, then what happens is that there will be opening of the fast sodium channels. So this opening of the fast sodium channel, or the phase of depolarization, is represented by the phase 0. Okay, so the resting membrane potential is -90 millivolt, and when a threshold potential is applied, then there will be opening of the fast sodium channels, and this opening of the fast sodium channels causes the cells to depolarize, and this phase of depolarization is called as the phase 0. The ionic basis is opening of the fast sodium channels. So once it shoots above 20 millivolt, then the fast sodium channels close immediately and the potassium channel begins to open. Okay, please pay attention here. So the fast sodium channel begins to close and the potassium channel begins to open, and that phase is called as the phase 1, or phase of initial repolarization. The phase 1 is called as a phase of initial repolarization, and during this phase the fast sodium channels that were open closes and begins to close, and the sodium channel begins to open.
But just as the sodium channel begins to, just as the potassium channel begins to open and the potassium efflux begins, at the same time, the calcium channel also open. Understood? The calcium channel is also open. So at one point, what is happening simultaneously is that the potassium is going out of the cell, but at the same time, the calcium is also coming. There is rapid influx of the calcium ions into the cell. So it kind of balances the, what do you call that? It kind of balances the charges within the cell because potassium is going out, but at the same time, calcium is coming in. So it kind of creates a stable situation, and that is the phase 2 or the plateau phase. So this plateau phase is the phase where the calcium channel begins to open and the potassium channel begins to close. Do you understand? Yes or no till now? Have you understood? Students, do you want me to repeat it?
Yes, ma'am.
What have you not understood? Who is this?
Ma'am, Akash, ma'am, from that
Who is this?
that part, ma'am, Akash.
Akash, okay. Akash, so do you remember the phases of action potential in the skeletal muscle fiber?
Yes, ma'am. Ma'am, I wanted to know from
what?
that when Kepler's channels open.
When calcium channels open.
Yeah, yeah.
Okay, initially, okay, you understand the phase 0 or the phase of
Yes, ma'am.
depolarization.
Yes, ma'am. Yes, ma'am.
Because the threshold stimulus has been applied, then there will be opening of fast sodium channels, and it will like take the action potential towards the more positive. There will be a firing or a phase of depolarization, isn't it? So once about 20 millivolt is reached, then what happens? The sodium channel begins to close. So when sodium channel begins to close, at the same time, the potassium channel begins to open, meaning that the potassium efflux starts from the cell. So it kind of starts a phase of repolarization. Yes or no?
Yes, ma'am.
Yes. So this phase or phase 1 is called as the phase of initial repolarization, because at the same time the potassium channel like opens, and just a few milliseconds later the calcium channel will also open in case of the cardiac muscle. So the cardiac muscle has to the calcium is moving extracellularly to intracellularly, isn't it? Towards the concentration gradient. Yes or no? So what happens is that during this phase, what is happening is that the potassium channel is open, but the calcium channel is also open. So there is a kind of balance in the charges that is flowing in and out or going out of the cells. Yes or no?
Yes.
Are you following? Yes. So this kind of gives a stable kind of graph, as you can see here, that is responsible for the plateau phase or phase 2. Yes. So once this happens for after a certain time, then this calcium channel will close and only potassium channel will remain open. And this potassium opening of this potassium channel will initiate the phase 3. This 3, which is characterized by, of course, whenever there is efflux of potassium out of the cell, then it is called as the phase of repolarization, and the cell will again gain its negative charge inside and it will return back to its normal resting potential, which is the phase 4. Understood?
Yes, ma'am. Thank you.
Yes? All right. All right. Thank you. So this is about the action potential of the cardiac muscle. So you can compare, you can go back, if you've forgotten, you can go back and compare how it is different from the action potential in the skeletal muscle. All right?
Okay. So this is also the same thing actually. So there is phase 0, which is the phase of depolarization. Phase 1, which is called as the phase of initial repolarization. Phase 2 here, it is a little, it's wrong. Okay, so don't follow this because it should say overshoot in 1, but rather than overshoot, it is actually initial repolarization and then followed by a plateau phase. And once the plateau phase is over, it is characterized by the phase of repolarization, which is phase 3, and then finally the phase of resting membrane potential, which is characterized by phase 4.
So the other, this is about the action potential in the cardiac muscle. But there are certain things that you have to remember here, the certain properties that the cardiac muscles exhibit when it is being excited is that number 1 is the property of the absolute refractory period. And I know that you are very well aware with this term, isn't it? So from this phase of depolarization, like phase 0, up to about 1/3, I think. Okay, I just exactly forgot. You take a look, up to almost half of the phase of the repolarization. What happens is that during that phase, no matter how much of external stimulus you give, no matter how much intensity of stimulus is applied to the cardiac muscle cell, it will not be able to be excited. And that property is called as the absolute refractory period of the cardiac muscle. So when you have applied a threshold potential and the depolarization has started, from that point up to the up to the phase about 1/3 of the repolarization phase, even no matter how much you excite this muscle, no matter how much of intensity of stimulus you apply to the cardiac muscle, it will not be able to be excited, and that characteristic or that property of the cardiac muscle cell is called as the absolute refractory period. However, after a certain point of time, that is usually about 2/3 portion of the repolarization, still normally you will not be able to excite the cell, but then if you apply excessive or high intensity of stimulus, then it might be capable of generating, or it might be capable of being excited again, and that property of the cardiac muscle is called as the relative refractory period. Okay, so these are the excitability changes during the cardiac muscle action potential. So this is quite important. There is absolute refractory period and there is relative refractory period. And I know that you are well acquainted with these terms. Now, can anybody tell me what could be the significance of this absolute refractory period? Manish.
Yes, ma'am.
Yes. Have you understood till now? Is it clear?
Yes, ma'am, it is clear.
Okay. So can you tell me what is the role, like we're talking about this importance of this absolute refractory period, what significance do you think that this absolute refractory period has? What difference does it make that whether the heart is being able to be excited or not?
It is the period in which no matter how strong is the
Yes.
stimulus, the cardiac
Yes.
muscle will not respond to it.
So what's
After
the point? What's the use that the cardiac muscle is not being able to be? Wouldn't it be good, like if you were able to excite it continuously over and over and over again? Can you think of any significance that this provides to the cardiac muscle? What is the significance of absolute refractory period? You've studied about this. All right, you don't remember, no problem. No problem. So whenever we say that the absolute refractory period, meaning that it can't be re-excited just when the muscle is being excited, it means that there is no chance of the muscle to be fatigued, and we do not want heart to develop a period of fatigue, isn't it? We don't want the heart to become lethargic, and we don't want the heart to become tired, because we always want the heart to have a rhythmic pattern to beat continuously. Because if the heart muscles fatigue, then that means that you know what that means, isn't it? So the significance of this refractory period in the case of the cardiac muscle, having a refractory period, the absolute as well as the relative, which provides quite a long duration of the refractory period, prevents the development of the fatigue within the cardiac muscle. Okay, so this is one of the very, very important feature of the refractory period in the cardiac muscles. So it does not allow the heart to fatigue. But then there are several other factors that also makes heart very unique and does not allow the heart to develop fatigue. So one of them is that of course you know it, the heart is a very, very rich blood supply, so that prevents fatigue. There is continuous supply of nutrients and oxygen to the heart. Then next is the aerobic metabolism, meaning that it always the metabolism occurs in the presence of the oxygen. So there is no development of the lactic acid, which would have been a product of the anaerobic or anaerobic metabolism rather, which is one of the very important contributory factor to the development of the fatigue. Similarly, if you take a look, if detail about the anatomical properties of the cardiac muscle, we know that it is very richly distributed with the mitochondria. So that richness of the mitochondria also prevents the heart from being fatigued. Okay, so this is about the cardiac muscles, especially in the ventricular muscle action potential. So this kind of covers the excitability of the heart. So in the excitability also, it covers the excitability of the fast action potential or the action potential that is seen in case of the ventricle and the atrium. The atrium is also just like this. It's just because the studies of the ventricles have been done in greater detail, so we always take the ventricular muscle fiber for reference. All right. Now let's come to the slow action potential. So as I've told you, the slow potential is seen in the SA node, and if you take a look at the resting membrane potential is also quite low, about -55 millivolt only. So it is quite different if you compare it with the skeletal muscle fiber, if you compare it with the cardiac muscle fiber, if you compare it with the nerve cell. So you can see that all of them have quite greater amount of resting membrane potential than the SA node. So in SA node it's quite small, that is about -55 millivolt. Okay, so this -55 millivolt of the resting membrane potential in case of the SA node is due to the, and you have to keep in mind here, it is due to the large concentration or higher concentration of the sodium in the extracellular fluid as well as the moderate number of already open sodium channels. So what it means is that in the SA node consists around the extracellular fluid component of the SA node already consists of like very great concentrations of the sodium ions, and at the same time, even when it is resting, in the resting phase also, it is leaky to the sodium channels. Okay, so it is because of this leakiness that the unique excitability or unique potential is seen in the SA node. So I'll show you a slide which shows a very the action potential, the what do you call this, the chart here, as you can see. So this is something you have not seen previously, isn't it? So you can see here that there is this unique membrane potential. The resting membrane potential is quite unique, as you can see here. It is quite unstable here. You can see that there is, even in the resting phase, the membrane potential has been rising spontaneously. So like I've told you, the SA node, the resting membrane potential is -50. Here it is shown -60. The average is -55, but it can range from -50 to -60 millivolt. So what happens is that at a resting membrane of -60 millivolt, so during this is the initial resting membrane potential of the SA nodal fibers. But then because of high concentration of the sodium as well as its leakiness to the sodium channels, what happens is that there will be, even in resting phase, there will be continuous influx of the sodium ion into the cell. So this continuous influx will continue to raise the cell membrane, isn't it? It will continue to raise the positivity in the resting state. Gradually, it will, due to the influx of the sodium ions and due to the opening of the leakiness of the sodium channels, there will be continuous influx of the sodium ions that will raise the potential from its initial -60 to -40 millivolt. So this is happening spontaneously without any application of stimulus. So once it reaches a threshold stimulus, which is about -40 millivolt, then what happens is that there will be opening of the calcium channels. So this opening of the calcium channels will cause the depolarization to happen. And once the depolarization phase is ending, then there will be opening of the potassium channels. Okay. This in turn will open the potassium channels, and this will bring the cells of the SA node back to its resting membrane potential of -55 to -60 millivolt. And once again, once it has reached its resting membrane potential, again there are sodium leaky channels, there is sodium, high concentration sodium, continuous influx inside the cell, and this is again raising the resting limit potential again to the threshold. So there is this continuous state potential which is called as the pre-potential, and this is quite unique as it is only seen in the SA nodal cells. Understood, everyone? Please go through the book, have a detailed study, and it won't be as difficult. But whenever in exams, you should be able to tell what is the excitability, what do you understand by it, what are the unique features of the cardiac muscle cell in terms of excitability, or the SA nodal cell in terms of excitability. Okay, so this is about the excitability of the cardiac muscle cells. Right, so what are the factors that can affect cardiac excitability? So what are the positively bathmotropic factors? What are the negatively bathmotropic factors is actually what we are trying to understand through this slide. So the innervation to the heart affects it. So we know that the heart is innervated. Mainly the heart is under the influence of the sympathetic and the parasympathetic nervous system. Similarly, there are various ion concentration that also affects the activities of the heart. There's certain physical factors, blood flow, as well as there's various drugs and substances that can affect the excitability of the heart. So in case if we take a look, we've already started the autonomic nervous system. So you know that the sympathetic nervous system is responsible not only for exciting the excitability of the heart, rather it increases all the aspects of the other functions of the heart, like the contractility, conductivity. So sympathetic nervous system is positively bathmotropic. Similarly, the parasympathetic or the vagus nerve reduces the excitability, and it is considered to be the negatively bathmotropic factor. And similarly, ions, we know that the calcium ion is very, very vital for the proper functioning of the heart. The calcium plays a very important role in increasing the contraction of the heart. Even it also increases the excitability of the heart. Similarly, the potassium ions decreases the excitability. So we can say that the calcium are the positively bathmotropic factors, and the potassium is the negatively bathmotropic factor. All right. Similarly, blood flow. So we know that blood is very, very essential for providing sufficient nutrients, lack of sufficient oxygen to the heart, which is essential for the good metabolism as well as the functioning of the heart. So if there is any discrepancy within these parameters, or if there is any lack, or if there is any any kind of abnormality, then all of these factors can lead to the reduced excitability of the heart. Similarly, one of the drugs that is very commonly used, commonly known, that is responsible for increasing the excitability are the digitalis. So what are the drugs that decreases the excitability? It is for you to find out. All right, everyone, is it clear till now or not? Students?
Yes, ma'am.
Hear me?
Yes.
Can you hear me? All
Yes,
right.
ma'am.
So this is about the first and foremost, most important characteristic or properties of the cardiac muscle. So that was excitability. So the next is a small topic because we're also heading towards the end of time, and I know that it's that during the day your concentration is way out of where it should be. So I'll just do with the second important property of the cardiac muscle, and that is conductivity. So like I've told you, conductivity is the capability of the heart to conduct the impulses. There is a special conducting system in the heart which comprises of various cells which are specifically responsible for the transmission of the impulses, or the conduction of the impulses. So this whole conductive system is responsible for the proper transmission of the impulses conducted to the heart. Similarly, it is because of this rhythmical pattern of contraction of the cardiac muscles that allows the atria to contract ahead of the ventricle, so that there is sufficient time for the atria to pump out the blood into the ventricles before the ventricles contract and distribute this blood throughout the body. All right. So if we take a look at this picture, then you can see that there is a green line, and that green actually lines, or the green what do you call that, pathways are denoting the, or it is representing the conducting system of the heart. So the heart, the impulses are generated within the sinoatrial node, the SA node, which is here, as you can see, just at the junction of the superior vena cava with the right atrium. So this is the SA node. It is called as the pacemaker of the heart because the impulses are generated here. It's the site of origin of the impulses. It controls the beating of the heart. So the impulses begin to be conducted from the SA node. From the SA node, the impulses is then spread through the atria. And to be spread through the atria, there are three different tracts here, as you can see, anterior, intermediate, and the posterior tract, and then which transmits the impulses throughout the atria. And then once the atria has been depolarized, then these impulses will be transmitted to the AV node. This is the point of demarcation between the atria and the ventricles. So once the atria has sufficiently depolarized, then the depolarization will spread to the ventricles via the AV node. And from the AV node, as it extends downwards, it is called as the atrioventricular bundle. And then this atrioventricular bundle, which is also called as the bundle of His, will divide into right and left branches. And they will extend through the ventricular septum downwards towards to the apex of the heart. And from the apex of the heart, they're again like coursing sideways. And then after coursing sideways, they are coming back to the base of the heart. So this is the entire pathway for the conduction of the impulses, and this is called as the conducting system of the heart. So the main site of origin of the cardiac impulses is the SA node. From the SA node via these three tracks, it spreads throughout the atria, from the atria to the AV node and then to the AV bundle. The AV bundle passes down to the ventricular septum, divides into right and left bundle branches, and these right and left bundle branches move towards the apex and then course sideways and then again extends upward. And these minute fibers, this after the bifurcation of the AV bundle, these fibers, as they proceed downwards and further redivide into smaller branches, they are called as the Purkinje fibers. I'm sure you've studied about it in anatomy. So this comprises the conducting system of the. So if we take a look at the SA node, so that is the main called as the pacemaker, like I've told you, because it is the site of the origin of the cardiac impulse and it controls the beating of the entire heart. It is self-excitatory, so actually it appears as a flat strip of the tissues or the specialized cardiac tissue, and it is situated in the junction of the superior vena cava with the right atrium. So the direction of the conduction, as you can see, the conduction never happens. It is always happening in the one-way direction. That is from the SA node towards the AV node, towards the bundle of His, towards the fibers. The impulse never spreads backwards. Okay, so the direction of impulse conduction is always forward and downward. So the impulse is generated in the SA node, like here, and spread to the entire atrium, which occurs via the three internodal tracts. The anterior is called as the Bachmann, this is the anterior tract, which is called as the Bachmann. And this tract of Bachmann also supplies to the atrium on the other side. Similarly, the middle internodal tract, which is called as the tract of Wickenham. Similarly, the posterior internodal tract, which is called as the tract of Thorel. So through these three different tracts, the depolarization spreads throughout the atrium. So once the depolarization has spread throughout the atrium, then to be spread to the ventricles, it has to pass through the AV node. And in the AV node, let me see. AV node, which is located in the posterior wall of the right atrium. So it is conducted very, very rapidly up to the AV node. However, once these impulses arrive at the AV node, then there will be delay. The conduction of impulses will now not be as rapid as it was in the from the SA node to the atria. That took only about 0.3 seconds. But if you take a look at the conduction velocity of the impulses in the AV node, it will be quite delayed, and that is called as the AV nodal delay. So the point of this delay is, like I've told you initially, because if the impulses passes very, very rapidly, then what happens is that the atria will contract, immediately the ventricles will contract. So it will cause the atria and the ventricles to contract at the same time. And that is not desired, because we desired that the atrial blood be distributed or be emptied into the ventricles, and then only the ventricles should contract, isn't it? So in order to allow that, in order to create a situation such that the ventricles are contracted a little later following the contraction of the atrium, this AV nodal delay plays an important role. So you can see here, this represents the conductive system of the heart. So you can see here that from the impulses from the SA node to the AV node are brought here in the AV node at about 0. It just takes about 0.03 second. But once it comes to the once it comes to the AV node, there is a delay, and from the AV node via the bundle of His to spread, the total delay is 0.16 seconds. So even though the impulses arise from the SA node to the AV node at a duration of 0.03 seconds, only after 0.16 second does it reach the ventricles. So you can see how much of delay has happened at this area, the area of the AV node and the area of the bundle of His. So this area has been manufactured, or it has been designed in such a way that impulses cannot be generated, cannot be conducted as quickly as it would have been possible in the SA node to the atrium. So that means that there is presence of very few intercalated disc here. There is very less gap junction. So all of these features aid for the delayed transmission of the impulses. So that from the SA node to AV node, it reaches within 0.03 seconds, but within the AV node itself, there will be delay of about 0.09 seconds. In the AV bundle, there will be slight, it will take 0.04 seconds. So the total delay is about 0.16 seconds before it reaches the ventricle. So from the SA node to the atria, it arrives within 0.03 second only, but from the AV node to the ventricles, it takes about 0.16 seconds. Okay, and this is aided and this is contributed by the very less number of the intercalated disc, very less number of the gap junctions between the cells, and that aids in the delayed transmission of the impulses, which in turn allows the atria to contract ahead of the ventricular contraction. All right, so the AV bundle. Students, are you getting me or not? Is it understandable? Am I going too fast? Is it not understandable? But I think you've started this before. Have you or not? Pratishma, has this been taught before in anatomy or anywhere elsewhere?
No, ma'am, not yet.
No. Are you understanding or not?
Yeah, ma'am, I'm understanding.
Yeah. Okay. If you don't understand, you can just my lecture has been prepared from Guyton, so for easy reference, you can just look up to Guyton. All right. You just have to go through it once, and this will also kind of help you. All right, so as the AV bundle, the same thing that I've told, the AV bundle passes downwards in the ventricular septum towards apex of the heart, and then there it will divide into right and left bundle branches. They're also called as the bundle of His, and then as they divide and proceed towards the apex, and they will divide into smaller fibers, which I've called as the Purkinje fibers. And the special features of these Purkinje fibers is that these Purkinje fibers will conduct the impulses very, 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 very quickly, because we know that the atria is a smaller muscle mass compared to the ventricles, and a ventricle is quite a large muscle mass in comparison to the atria, and we know that the ventricles have to contract, both the ventricles have to contract at the same time for the pumping of the blood out of the ventricles into the body. So it is essential that the ventricles has to contract, this quite large muscle mass has to contract simultaneously, and this is aided by this fast conducting Purkinje fibers. So if you now take a general look at the conducting system, the SA node conduction velocity is good, 0.03 second. Very slow in AV node and bundle of His, and then it is very, very fast in case of the Purkinje fibers. All right, it is about 1.5 to 4 millimeter per second. So you can see how quick it is. It's very, very quick transmission. And this is due to by the very, 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 very large number of the gap junctions at the intercalated disc between those cells. So you can see how beautifully our heart is designed. There's so much of thought, so much of intellect that has gone into operating of the heart. It has been designed so well. Each cell has been carefully looked at, and it's a miracle. All right. So what are the factors affecting the conductivity? Same as that of the same factors like in case of the excitability, innervation, sympathetic will increase conductivity, parasympathetic will decrease conductivity. Similar, the same thing is with the ions also. Calcium ions will increase it, potassium ions will decrease it. The physical factors, you can just go through them, and then blood flow, the chemical factors. So everything is same as that of the factors that affect the excitability of the cell. Understood, everyone? So
Yes,
what are
ma'am.
the factors that affect the conductivity of? What are those factors? Like we say bathymotropic, what are the factors which affect the conductivity? They're called. Manish. Any idea what it is called? Bathymotropic, chromotropic, inotropic. Have you heard about these terms or not? Have you heard about these terms?
Yours. I'm not audible properly.
Okay, have you heard the terms such as the chronotropic, inotropic, chromotropic, bathymotropic? Have you heard these terms or not?
Yes, ma'am.
What is bathymotropic, Manish?
That is related to conductivity of heart.
Bathymotropic is related to conductivity. Then what is related to the excitability?
I'm sorry, ma'am. Excitability of heart is bathymotropic.
Then you find out, okay, what is the specific term that we use to denote the conductivity of the heart. All right, in next class, I'll ask you. Okay?
Okay, ma'am.
Okay. Have you understood Manish today? Was it audible? Was it clear? Was it too
Yes.
fast, too slow? Is it okay? Is it okay?
It's okay, ma'am.
All right. All right. So that's it for today. If you have any questions, any queries, any things that you want to ask, please make sure that you drop your message. So some of you have dropped me a message, ma'am, your voice is not clearly audible. Well, I just saw that message right now, 3:14, all right, 8:14. Okay, so whatever. Okay, so students, have a good day, and I'll see you tomorrow. I think I have a class tomorrow also, so tomorrow we will continue the remaining of the topic. All right, have a good day. Bye bye.
Thank you, ma'am.